Hello, everybody. My name is James Downs. This is my Comprehensive Geriatric Assessment, or CGA, presentation for FNP4. Brief overview. What is the CGA? Why is it important? We'll go through a case presentation that includes a geriatric assessment specifically, and then have a discussion at the end. So what is the CGA? It's an assessment which addresses the complex problems that elderly patients suffer with. Covers the patient's needs and utilizes an interdisciplinary team to really focus on and identify all of those issues that include functional decline, cognitive decline that patients develop over time. As our patients age out in practice, we'll start seeing some declining, and we might even see some things in ourselves. Why is it important? It's important because the CGA covers these aspects of a patient's status that could contribute to poor outcomes over time. That could be hazards in the home that maybe things that weren't a hazard initially, like a step up into the home, might become a bigger deal. A declining ability to care for the self is also a big deal. The CGA addresses the 5 I's of geriatrics: intellectual impairments, immobility or declining mobility, instability, incontinence, and iatrogenic issues. So we'll go through the case presentation now. Patient came in, 78-year-old white female, presented with sudden onset vertigo symptoms and multiple falls. She woke up 2 days ago with dizziness, and when getting out of bed, she discovered her gait was unsteady, with difficulty ambulating and poor coordination. She expressed an inability to steady her gait. She had a fall while ambulating in her kitchen soon after. She had a second fall from her bathroom toilet when a dizzy spell caused her to crash into the cabinet. She called EMS using her cell phone at this point, and she presented to the ER. She stated she had vertigo in the past with a fall, but these new episodes were more severe. Today, in the hospital, she denies headache or dizziness, spinning sensation or lightheadedness or otherwise. She denied headache, change of vision, chest pain, unilateral arm, leg, or weakness since the episodes. I just want to pause real quick and say my clinical rotation is in the hospital with a hospitalist nurse practitioner. We see med-surg patients and observation state patients. This is one of these patients. Past medical history include depression, breast cancer, chemo-induced neuropathy in the bilateral lower extremities, which is pretty significant contributor to her falling in the past. And surgical history, she's got cholecystectomy, right cataract eye removal, and vitrectomy, hemorrhoid ligation, and partial right mastectomy in 2017. Family history, hypertension, and stroke in maternal grandmother, paternal grandfather, and cousin have cancer. Allergies are listed below. Current medication, sertraline, zinc, multivitamin, gabapentin, Ambien, Magox, meloxicam, exemestane, vitamin D, another vitamin, and synthesides. Sexual history, never smoker, no alcohol or drug use, no smokeless tobacco, lives at home alone, does have family that comes and visits, endorses social support, friends, church group activities, says she has good healthcare insurance, she's retired, not working, transportation and finances aren't really an issue for her. On the ROS, no, like I stated, no dizziness, no neurovascular symptoms, no neuro symptoms, neuromuscular symptoms, dizzy spell since the admission. So since she's come in, she actually hasn't had these symptoms. She did state when I was talking with her that when this dizziness comes, it's almost like she just gets thrown across the room. She loses her balance and just falls. She does say she feels a little tired, a little bit lethargic and slower. Musculoskeletally, she doesn't endorse slight difficulty ambulating, but no serious difficulty, not requiring cane or walker or anything like that. So physical exam, vitals were good. Blood pressure is slightly elevated. BMI is appropriate. Unremarkable. Imaging, CT of the head and neck, no acute process, and MRI of the brain, no acute changes. These were all found. CT and head and neck was in the ER, and MRI was later on, but there was no acute changes in the brain, which is helpful when identifying, or was this a transient ischemic attack or something like that? Could have caused these symptoms, these ataxia and vertigo symptoms. On the physical exam, really nothing stood out. Other than when she was ambulating, she ambulated in the room with little difficulty. She's able to stand up by herself without getting out of the chair, or without using her arms to get out of the chair. She was able to walk about 5 paces, turn around, return, sit back to the chair without an aid. Gait was slightly irregular, however. There's a slight drift, and she had a bit of a wide stance in order to maintain balance upright. Her grip strength is 5 out of 5, upper and lower extremities. Otherwise, nothing Nothing seemed out of the ordinary. So where does the comprehensive geriatric assessment fit in? So I kind of just threw this under after the objective and this objective because it kind of has a bit of both. The evaluations were done have a bit of both subjective and objective information in there. Underneath the five eyes, I have the different screenings that I did with this patient, and then on the side here on the right, I have others that we covered. So for intellectual impairments, doing the PHQ-2, the patient it was all normal. The patient does have a history of depression, but she is on an SSRI, and that is well controlled. I did the mini cog with this patient, and basically that screening was negative for any cognitive difficulty, instability, doing the Tenetti balance risk assessment, and um, in light of recent falls in the past couple of years, she did determine her to be a moderate risk of falls. So should be considering therapy. Immobility, declining immobility, the functional status of this patient was normal. She was able to do and display ability to perform assessment activities of daily living. Fall risk assessment, during the timed up and go test, she did take a little over 12 seconds. So means she's a bit a bit of an increased risk for falls. And so home therapy or outpatient physical therapy will be recommended for her just to get up her strength and work on improving her gait. Incontinence, no issues were found with her. Medication review, stop, start tools, and Beers list. No Beers medications. This patient stop tool, start tool. Nothing seemed really inappropriate. Now, the meloxicam was stopped by neurology. When they were consulting the patient, they did say stop utilizing this medication, so they stopped that. But otherwise, stop medications. No potentially inappropriate medications were found, and utilizing the start tool because the patient doesn't have an explicit history of a coronary cerebral or peripheral vascular disease, then there is an indication for antiplatelet therapy. However, the patient does have a history of hyperlipidemia. Her grandmother does have a history of stroke and hypertension, and so it would be important to evaluate this patient further for cardiovascular disease or peripheral vascular disease or cerebrovascular disease. On a nutritional assessment, the patient did score a 12 on the mini nutritional assessment. And so we'll be recommending for this patient uh, a specific diet therapy for the Mediterranean diet, given potential cerebrovascular etiology of the ataxia and the vertigo, and also given her hyperlipidemia risk factor. But again, we actually don't have lipid values on her, and that would be something that drawing a lipid panel would be something very important to do for her so we can assess risk and whatnot. Hearing loss screen and vision loss screen. The patient goes annually for hearing loss and every 6 months for vision loss. She does have her glasses and her vision's perfect with the glasses on. Healthy lifestyle counseling was reviewed with the patient, things like exercise and diet, which we'll talk about in a minute. Pain, she doesn't really have any pain, actually, surprisingly. Maybe a little bit of joint pain, but nothing serious. And I mean, that could be possibly why she takes the meloxicam. I'm just thinking of this now, but that's going to be stopped. So that would actually be something in addition to review with the patient. Financial situation, the patient states she is no financial difficulty. Health insurance is good. Is DNRCCA, does have a living will and a healthcare power of attorney. Just briefly here, I included the USPSTF recommendations, both for screenings and then for immunizations. Of note, the patient was up to date on her immunizations, including the DTaP and the Shingrix. So for this patient, it's important to screen for hypertension. So that's an outpatient thing because we do need two different, blood pressures on different days. And the hospital tends to elevate blood pressure anyway because of the stressful situation. And so that would be important to do on outpatient. She is on a aromatase inhibitor for breast cancer, past history of breast cancer. So that's a Class B recommendation. Also, Class B recommendation is the fall prevention, adults over 64, which we did in the screening. I mean, um, diet, so decrease cardiovascular risk, Class B recommendation, also discussed later on. Osteoporosis can be done in women older than 65, screen for, and utilizing the score, the OSIRIS, and or the FRAX. So those that's a Class B recommendation as well. And then for the fall prevention, for patients who are over older than 65 in our community dwelling, it's a Class C recommendation, but given the patient's fall history and contributing conditions, it's important to screen for this and make sure that the patient is discharged. If she will be discharged home, that the patient will be discharged safely. So now on to assessment. So primary problems, new contributing problems. So ataxia, dizziness, history of falls. These three are new, and then drug-induced polyneuropathy that's actually passed. So the drug-induced polyneuropathy, as we'll discuss, is related to her breast cancer treatment. So other problems, hyperlipidemia, breast cancer, and depression. So what's the plan for this patient? The dizziness and suspected vertigo in the ER. She had EKG. There's no ST changes. No cardiac abnormalities. Honestly, and the EKG troponin was negative, so they kind of ruled out cardiac issue there. She was on meclizine for antivert for the vertigo. There's plans for her to follow the ENT outpatient for the vertigo symptoms, and then neurology was consulted on her, which that was mostly for the ataxia and ruling out cerebrovascular problems here. Recommended the patient obtain a life alert button because the patient, when she did fall the second time, she fortunately had her cell phone with her, but she had the vertigo. She was on the ground and she wasn't able to get up initially for a while. And having a life alert would be increase patient safety there. Ataxia. So this ataxia is new. It's basically not. It's basically been resolved since she was admitted. Neurology was seeing her. They stopped the meloxicam. She did get a uh, one dose of aspirin and Plavix. And so basically, we'll be following up outpatient neuro with her. And also therapy was consulted and was evaluated, and it was determined that she would benefit from outpatient visit. History of falls. So just like what we did, home safety assessment, screen for functional decline, ensure adequate performance of ADL, IDL, prior to discharge. And then we'll be doing a pharmaceutical review just to identify potentially medications that are contributing to the history of falling. Drug-induced polyneuropathy, this is the main contributor, and the patient told me that when she first developed the polyneuropathy in the bilateral lower extremities and a little bit in her hands, um, she fell all the time. And so this would be something that we need to be making sure we're on top of and treating. And she says she's basically she's adapted to the altered sensation in the lower extremities, and so she hasn't really fallen from that. All these falls are just this new vertigo and ataxia symptoms. So we'll be continuing her gabapentin, hyperlipidemia, no lipid panel was done, so we're doing that. Likely be done outpatient because we basically ended up discharging her on this day. Cardiovascular disease risk, we'll screen for hypertension outpatient, and initiate her healthy diet, including the Mediterranean diet. And then we'll continue aromasin for history of breast cancer and continue SSRI for history of depression. Of note, the reason we do depression screen is because functional status declines in patients, elderly patients with depression, as because of weight loss, because of there's actually noted to be an increase in mortality and risk of suicide in these patients. And the result is higher utilization of healthcare resources. Patient education, heart healthy diet, things to avoid when cooking, how to cook healthier, med side effects. So Anavar can cause drowsiness, fatigue, constipation, blurry vision, and then just educating her why she received aspirin, a dose of aspirin or Plavix, and why we're not going to continue that necessarily because it's not indicated unless there's evidence for cardiovascular disease. But that would be something that her primary care doctor is going to have to address. That would be something that we in the outpatient setting would address. And then notify the physician recurring ataxic episodes, vertigo or fall, alter mental status, confusion, muscle weakness on one or both sides of the body. Basically, just signs of maybe a stroke here. So the patient's aware. And then this would also be something to educate the family about as well and the social contacts. And then, yes, continue change of vision, hearing, droop on the side of the face, recurrence of depressive symptoms. And then also meds to avoid right now is just over-the-counter NSAIDs such as ibuprofen, Motrin, naproxen, or Aleve. And then just of note, meloxicam was discontinued. Advanced care planning. So interdisciplinary approach to ensuring the patient is discharged into a safe environment is critical to basically meet not just like patient safety goals, but also patients' life quality goals. So discharging patients like utilizing or including the patient in the discharge discussion is important in order to adequately meet their needs and also what they want for their care, what they want their care to look like. And so for this patient, neurology, physical therapy, case management, hospital medicine are all together, and also nutrition, I believe, in order to discharge the patient, uh, meeting their needs and their requests, and also their safety uh, recommendations. And of course, we're educating the patient the whole time about why we're doing what we're doing. And then for follow-up, PCP follow-up in 1 week was scheduled. Follow-up with neurology outpatient in about 2 weeks, there's an appointment scheduled. And then for following the home PT recommendations, the point being to regain normal neuromotor function and gait stability and to prevent fall recurrence. And then she does have a cane at home as a walker, as a ambulation aid. And then she'll be wanting to keep follow with eye and ear physicians as well. So in summary, it's important for the comprehensive geriatric assessment to be done on patients who we believe to be at risk for functional and cognitive decline. It's 1/3 of persons over 65 and half of persons over 80 fall each year. Falls are a major contributor to deterioration of health in the elderly. Once a fall happens, particularly when there's a bone break, I'm sure we all know the statistics on femur fracture and further deterioration, but that's something that we want to avoid in our elderly patients. So the CGA is designed to identify the needs of an aging population. Overall health and quality of life is improved through the interdisciplinary assessment of the patient. Experts working on their fields can help identify what in the patient's life needs to be adjusted, what practices, what safety implementations for improving patient safety need to be done, all for the purpose of reducing poor outcomes and improving good outcomes. So was this comprehensive geriatric assessment good for our patient? In short, yes, and it covered the patient would benefit from physical therapy, often in the hospital. Patients, if the doctor says they're doing fairly well and says back to their baseline, then basically we can discharge them back to home, given that their baseline is functional. However, for this patient, she wasn't quite at her baseline yet, and so identifying that was helpful in having therapy orders for her in order to regain her functional baseline, hopefully. Also, sometimes it can be missed, but just identifying what medications might be contraindicated for her age, her comorbidities, and whatnot. And this being meloxicam was important because it does increase the risk of cardiovascular and like stroke, as an NSAID. And then follow up with neurology. The neurology team being on, they went to follow up with her, and that could also be helpful in improving her further deterioration in one direction or another. And then that is it. Here's my references. And that is essentially my presentation. Thank you very much.